Right, good evening, everybody. Welcome to our SEEDS series of webinar lectures. Today, we have got two very interesting topics. One is on surgical management of infectious lung disease by Dr. Antonio Ramos from Philippines. And the next is the use of adjunct hemostatic agents in thoracic surgery by Mr. Soon Sing Young from Malaysia. A quick introduction on both of our speakers. Dr. Antonio Ramos is a consultant cardiothoracic and vascular surgeon from the Philippines. He graduated in University of Philippines and he's got a fellow under the Lung Center of Philippines Thoracic Surgery. And currently he runs a few administrative duties and he's got affiliation with Stanford University of Medical Center. His main interest is in bronchogenic carcinoma, pulmonary aspergilloma, aortic aneurysm, and tuberculosis surgery. Mr. Soon Sing Young is a consultant cardiothoracic surgeon from Kuching, Sarawak, and he's with the Ministry of Health Malaysia. He has got a fellow from Royal College of Surgeons in 2009, and he's been one of the main thoracic surgeons from Malaysia and basically championing the VAT surgery in Malaysia. So I'm not going to take much time. The floor is yours, Dr. Antonio. We can start on with surgical management of infectious lung disease. Thank you.
Thank you. Thank you, Dr. Siva. I'd like to thank the SEEDS for this very kind invitation. I miss doing lectures. This is the Lung Center of the Philippines where I work. The topic assigned to me is surgical management of infectious lung diseases. And I've decided to group this into two. One is the sequelae of bacterial pneumonia. The other is the sequelae of pulmonary tuberculosis. Under bacterial pneumonia sequelae, you have your loculated pleural effusions, empyema thoracis, and then the restrictive lung disease or the trapped lung. Under pulmonary TB sequelae, you have your bronchiectasis, secondary tuberculosis, restrictive lung disease, hemoptysis, which is a special topic in itself, and aspergiloma, which is usually secondary to an old TB lesion. So we start with bacterial pneumonia sequelae. The first is loculated pleural effusion. In neglected or unrecognized bacterial pneumonias, it progresses to the stage where you have effusion, and then if it is still not treated, it loculates. And to be able to visualize and to quantify the amount of fluid, an ultrasound is very important. It also tells you where to put in your drain. A chest CT scan is also good because it gives you a good roadmap of the pleural space. You know where most of the fluid is, the biggest loculation, where it is located. And since most of this is not very difficult to do, surgical management would be VATS deloculation. We usually put in a port, put in the camera, use the ovum forceps and the suction catheter to clean it out, and then put in a nice drain. The second is when the loculated or pleural effusion secondary to pneumonia progresses. And then it becomes empyema thoracis or the presence of pus inside the pleural cavity. Again, of course, ultrasound and chest CT scan is very important. Now, surgical management is a little different because you need to put in large bore chest tubes, French 28, or we still put in 32s for the very thick purulent material. If it is loculated empyema thoracis, it may be better to do VATS, so you will be able to clean out the chest. You can even do lavage, and position your drains optimally so you will have good drainage. But in some cases, patient is emaciated, immunocompromised, very poor nutrition. We used to do pleural window. A pleural window is putting in resecting two ribs about 5 centimeters long and then lining the hole with the skin. It allows for continuous drainage of the purulent material in the pleural cavity. Now, what do I always tell the fellows about this? If you're putting in a chest tube for empyema thoracis, do not remove it early. It's better to remove it late because if you have a recurrence of the infection, if the infection is not adequately controlled, then it's going to be more difficult to put in a chest tube the next time. So what I do, instead of 100 ml per day, if it's 50 ml per day, that's the time I remove it. If the patient is not febrile, or if the infectious disease consultant feels that they've given enough antibiotic treatment, then that's the only time I remove the chest drain, the large bore chest tube. I even send patients home with the chest tube and ask them to come back for us to remove it. The next sequelae of bacterial pneumonia is if the empyema thoracis is not adequately drained, and there is still some infection, and then it is chronic, then the visceral pleura and the parietal pleura becomes thick, and then it's a restrictive lung disease. It's also termed trapped lung. Now, for the diagnosis, to be able to say that you have restrictive lung disease or a trapped lung, aside from the image in the CT scan, it's important that we also do a pulmonary function test to see if it's really worth doing, it's worth managing. And the pulmonary function test for restrictive lung disease should tell you that the FVC, or the forced vital capacity, is down, even in the presence of a normal FEV1 over FVC ratio. Anyway, it will be read by the pulmonologist, and they will say if the patient has significant restrictive lung disease, then it's worth the risk of doing surgery. And since the visceral pleural peel in bacterial pneumonia is quite easy to remove, the decortication usually just needs a VATS. You only do a thoracotomy if you encounter difficulties, but I think for the most part, or if not for all cases, a VATS should be sufficient to be able to remove the thickened visceral peel and to allow the lung to expand and therefore relieve the restrictive lung disease. Pointers, of course, it's very important to define the status of the underlying lung parenchyma. Why? Because if you're doing decortication, only to find out that the lung would not expand or is diseased in itself, then you have to go ahead and resect it. So if you know prior to doing your decortication the status of the lung or the lobe, then you can do an outright lobectomy and not have to decorticate that diseased lung. And also, since we sometimes encounter incomplete lung expansion or the pleural space after do decortication, it's very important that aggressive post-operative pulmonary care is done for these patients. Now we go to the more difficult part, which is TB sequelae. Okay. The first part that we'll see is the bronchiectasis. This is the destruction of the abnormality of the bronchus in the affected lobe. The usual presentation is chronic productive cough. These patients have productive cough for years and years. And then, of course, it is diagnosed by chest CT scan. I placed here bronchography because I'm now still in training. We used to do bronchography. You guys must not be seeing this anymore. We put in a nasotracheal tube and thread it down the left and right bronchus, and then put water-soluble dye and take X-rays in different positions to define the dilatation in the different in the bronchial tree. So, but now you have your high-resolution chest CT scan, so that should be sufficient. Sputum TB studies I mentioned here because it's important before we do any surgery on the chest, especially for the lungs. You should know the TB status of the patient. If the patient is sputum positive, it would be best to institute anti-TB treatment at least for 14 days because they say that's enough to convert the patient from a sputum positive, sputum negative. The reason why we want to do that is you have less complications if you operate on a sputum negative, TB negative patient. Airway management is very important during surgery for these cases wherein you need to do resection of the affected lobe or lobes. You can do a thoracotomy or VATS, whichever you are more comfortable with. The reason why I'm stressing airway management is because now we have the bronchial blockade and then we have the double lumen endotracheal tubes. To prevent the spillage of infected material from the operative side, which is on the upper part, going to the dependent area. And you're going to contaminate the other lung if you do not have good airway management. Now, unique about bronchiectasis in TB is because, as we know, TB usually involves the upper lobes, and the upper lobes are more adjacent to major blood vessels, aside from the subclavian in both apices. You have the vena cava on the right and the aorta on the left. And if you have a contracted or a carnified lung, you know, the volume of the lung is so fibrous, no? It is so little that you may be encountering quote unquote an abnormal hilar anatomy because it's pulled up. So even the blood vessels in the airway you don't find them in the usual places. Sometimes they're twisted. And that is why it's nice to sit down with your radiologist and discuss the preoperative chest CT scan so you can actually map out your surgery, know where you're going to look for the blood vessels, and know where you're going to find the airway. And of course, in patients with TB, in TB, you have in chronic infection, you risk bronchial stump problems. And for this, they become friable because of this. And what we do is we do intercostal muscle reinforcement. You get a strip of intercostal muscle, wrap it around the stump, and place a few reinforcing sutures to make sure that stump is vascularized. Sometimes it's so difficult to do dissection, so you may need to do extrapleural dissection. And but of course that will entail some bleeding again because of the neovascularization from the chest wall going now into the pleural lining. When I was in training, we used to do a lot of rib resections because the chest is so contracted that you cannot use your rib retractors anymore. You have to resect several ribs to access the pleural cavity, the chest cavity. Of course, we don't do that anymore. Then you have your restrictive lung disease or your trapped lung. Again, these are patients who had TB before and diseased lung, and you have dyspnea and exertion. Again, sputum TB studies, very important, not to do surgery on sputum positive patients. And then a pulmonary function test, as I mentioned earlier. Now, the chest CT scan, as I also mentioned earlier, is very important because we want to find out if you're going to do a decortication, how is the underlying lung parenchyma? Is it worth saving or do you have to remove it? So a decortication is usually done via thoracotomy for pulmonary TB restrictive lung disease because it is sometimes possible and very possible many times that you do not have a pleural space. The visceral pleura and the parietal pleura are adherent to each other and you cannot put in your scope there. So as I mentioned earlier, you should define the underlying lung parenchyma status. And if you're going to do a decortication for TB, it's very important that when you try to remove the visceral pleura, you dissect the visceral pleura away from the lung and not the lung away from the pleura to minimize damage to the very friable lung underneath the thickened pleura. So very slowly, and because you have the possibility of incompletely filled pleural space or you have air leaks because of the decortication, you should have good drainage and post-operative pulmonary care, as I mentioned earlier. Hemoptysis is very common in tuberculosis, and in the history, we try to see, is it minimal from blood-streaked sputum to massive. Massive hemoptysis means life-threatening or causing asphyxiation or too much that the patient does not have air exchange anymore. Or if it is recurrent, the first time, second time, or it happens all the time, it's very important in decision-making. Very important to do for diagnosis is fiber optic bronchoscopy to locate the source, because in many instances, you have bilateral lesions and you should be able to tell where the bleeding is coming from. So be sure to remove the lesion which is causing the hemoptysis. And you'll be telling the patients, the bleedings come from the left, you have a lesion on the right also, so the one on the right might bleed in the future. Sputum TB studies, as I mentioned earlier, and of course, chest CT scan to map out the left and right lung, so we'll know where the abnormalities are, and then the bronchoscopy will tell you where the bleeding is coming from. Surgical management. A patient comes to the emergency room with massive hemoptysis. We used to do surgery immediately, and it was accompanied very high morbidity and mortality. But now in the presence of bronchial blockade, we can use Fogarty catheters, we can use the easy blockers of the anesthesiologist. It's 2 Fogarty catheters in one, like we cut one and then we use the other one to block main bronchus, either the left and the right. So now we can convert an emergency surgery to almost an elective surgery. And then it gives you time to control hypertension, support the heart, kidneys, diabetes control. Then you can do the surgery. And when you're doing the surgery, you need excellent lung isolation to prevent spillage, as I mentioned earlier. And for this, you may need to do a resection of a lobe or even a bilobe. You can do VATS, as what we've been doing now. Of course, when I was still in training, it was thoracotomy, and we even did prone thoracotomy. You can use a single lumen endotracheal tube, put the patient in prone, the dependent side being the affected side, then you operate on the dependent area. It's very difficult on the back of the surgeon, and most especially of the assistant. The pointers. It's important, as I mentioned earlier, to locate the bleeding source, especially for bilateral lesions, so you'd be sure that you are really addressing the hemoptysis. Bronchial blockade is very important to convert an urgent to an elective surgery. Now, during the resection, whatever you're doing, if you're doing VATS or open thoracotomy, what we do is we control the bronchus first. We put in a vascular clamp on the bronchus, on the upper lobe usually. And then now you can work, because you do not fear that a hemoptysis episode will happen. It will flood your airway. So we look for the bronchus first, upper lobe bronchus, and then we control it with the vascular clamp. Aspergiloma is a very familiar topic to me. I wrote a paper on aspergilloma when I was in training. And it presents either as hemoptysis or a typical chest image of the monod sign or a fungus ball. The monod sign is a fungus ball inside the TB cavity, and which moves with the change in position. Mycetoma is another name for this. And just like the other causes of bleeding, you need to do fiber optic bronchoscopy, chest CT scan. But the pulmonologists in our hospital, they request for fungal studies. I don't know if they're doing it because it changes their management, or they just want it for their documentation. The surgical management, if with hemoptysis, then you do initial bronchial blockade. And then during the surgery, you need to do excellent lung isolation. As I mentioned earlier, you need to resect the lobe where the aspergilloma is. You can either do it VATS or thoracotomy. Pointers, usually the upper lobes are involved, so, and the dense surrounding lung parenchyma is there, and sometimes you cannot deploy very good staplers, and you have to hand sew the adjacent lung parenchyma if you want to control this. And you have the same issues with bronchiectasis. Now, VATS as a means of addressing the surgical, doing resections for tuberculosis has been proven even way before in 2012. Of course, unless you need to do a pneumonectomy, but it's now being done. Or but thoracoplasty. We used to do thoracoplasties. It's a major challenge for VATS. At the Lung Center of the Philippines, from year 2000 to 2012, we tried to do a review. Actually, this was my paper. 121 cases were done. No, my paper was earlier than 2000 to 2002, but this one was 90 to 92, but this one is a later paper rather. So 121 cases, open surgery done for complex pulmonary aspergillomas with a 24.7 morbidity rate and a 3.3% mortality rate. When we started doing VATS, we started recording our results from 2014 to 2017 at the Lung Center of the Philippines. 53 patients undergoing VATS lung resection for complex pulmonary aspergilloma. After the surgeries, chest tubes were inserted. Removal protocol of the chest tubes were daily output less than 100 ml, no air leaks, and expanded lung chest x-ray. No perioperative anti-fungal treatment was done. And TB medications were given if the specimen later proves to be positive for mycobacterial tuberculosis. We had 53 patients, mostly males. And we had comorbids, basically diabetes and hypertension. This is a typical chest CT scan of patients with Aspergiloma, as I mentioned earlier. You have bilateral disease, but you can see on the left lung, you have the Aspergiloma. It's a somewhat rounded lesion inside the TB cavity. And in this particular case, it was the one which was bleeding. So we had to do a left upper lobe resection. As I mentioned earlier, it is the upper lobes which are usually affected because the Aspergilloma resides in the TB cavity, and TB usually found in the upper lobes. So 79% are in the upper lobes, and only 9% in the lower lobes. So the mean OR time is 318 minutes, and as I mentioned, it's so difficult to do TB surgery for Aspergilloma because of the chronic condition. And this is because of extensive lymphadenopathies around the hilum. You have your pulmonary fibrosis and very, very dense adhesions. So we had 4 conversions for that series, 2 from bleeding and 2 from non-progress of the dissection. We had the 11.3% morbidities, mostly from empyema and atelectasis. Significantly, there were no mortalities in this series. And 83% were negative for TB. So we had to give anti-TB in the 17%. So surgery for hemoptysis is usually accompanied by high morbidity and high mortality rates, but VATS proved to give us better results now. And as I mentioned earlier, you should have good lung isolation to have better outcomes. And of course, proper patient selection and, as I mentioned, excellent airway management. So this is what we're doing now, VATS for complex pulmonary Aspergilloma, comparable results with open surgery. And if you compare this, you have just a 5 or 6 centimeter incision, depending on the extent of the specimen you bring out. We use a Jackson-Pratt drain. Patient goes home in a few days with less pain. So I'd like to thank, finally, I'd like to thank the SEATS, Southeast Asian Thoracic Surgeon Society, for giving me this chance to lecture while, as I mentioned to my friend, Brother Sun earlier, we're concentrating on the pandemic right now, and this is a picture of one of our patients going home. We should not neglect our cancer patients and our TB patients as well. So thank you very much.
Thank you very much, Dr. Antonio. Now we'll move on next to Mr. Sun. I think we will take the questions at the end of the session. Right now I have no Q&As yet, so we'll have to do it at the end. So Mr. Sun will be speaking on use of adjunct hemostatic agent in thoracic surgery. The floor is yours, Mr. Sun. Thank you.
Okay. Thank you, Siva. Thank you, Tony, for the excellent talk. Certainly when I visited your center, I was very impressed with how you guys deal with the very complex Aspergilloma that frequently presents to your center. So I must say, congratulations on an excellent series. It was really impressive to see how you guys work around the complex surgical management of Aspergilloma in your center.
Thank you, sir.
Yeah. So my talk today is use of hemostatic matrix in thoracic surgery. I'm putting on an industry cap for this talk, so pardon me for some advertisement. So issues with bleeding in thoracic surgery can be a few. So what are the issues that has to do with bleeding in thoracic surgery? We often find that patients present to us with preoperative anticoagulations. A lot of our patients are smokers, either ex-smokers or current smokers. And they not only have the lung cancer, but they also are predisposed to having ischemic heart disease, or they are also arteriopath, and they have strokes in the past, and they are on antiplatelets for that. So some of them are on single antiplatelets, and some of them are on dual antiplatelets. A lot of the patients that you come for present to you with lung cancer may also, when you are screening them, have signs of symptoms of ischemic heart disease, and you send them for an angiogram, and they have significant blockages in the arteries of their heart, and they will be stented by the cardiologist. And as you know, that when you have a stent being freshly placed in the coronary arteries, a lot of them need at least 1 month of dual antiplatelets therapy. So when you operate on such patients, obviously they are going to be a little bit coagulopathic. Some of our patients also are in atrial fibrillations and are on NOACs for that. So my policy of dealing with such patients is to stop the NOACs 5 days beforehand and to convert them to Claxane and to stop the Claxane 24 hours prior to surgery. Some of the patients may have mechanical heart valves in them and require warfarinization. And I usually operate on them. I stop the warfarin maybe about 3 days beforehand. And if the INR is less than 2, I will operate on them just because of the modern hemostats that is available to us. So for the patients that is on dual antiplatelets therapy, I usually prefer to wait until they are on single antiplatelet therapy. So if they're just on aspirin itself, that doesn't really present much of a bleeding issue at around the time of surgery. So what other issues are there? So patients can be on supplements. Some of them are taking traditional medicines and they may not inform you of that. As you know that some of the traditional medicines that the patients are taking can predispose them to bleeding. Recently, we have a patient that underwent cardiac surgery without informing us that he was on supplements, and he had post-operative bleeding requiring transfusion of fresh frozen plasma and also platelets. So it just you just need to be aware of some of the questions that you need to routinely ask the patients before surgery, certainly in this part of the world, because a lot of patients are on traditional treatments. A lot of our patients are also present to us after neoadjuvant therapy, especially after chemotherapy or chemoradiotherapy for stage 3 disease, or increasingly, a lot of them are presenting to us after neoadjuvant TKIs. The increasing trend would be for the use of immunotherapies in the neoadjuvant setting in the future. So all this neoadjuvant therapy would present the patients with probably adhesions, especially around the hilar structures or onto the chest wall. So when you dissect around all these hilar structures, it may be more raw areas, or they might be vessel injury to the hilar structures. The other issue is that patients can be referred to you for redo surgery. For example, recently we have a patient that had a middle lobe adeno-CA, EGFR negative, removed 2 years ago. And I presented last year with a new lesion in the right upper lobe, adeno-CA as well, with that is EGFR positive, that we did the redo surgery for. So they have adhesions that we need to be wary of. And also, as Tony has very eloquently described, patients with inflammatory or infectious lung diseases, they will have multiple issues of adhesions, especially around the hilar structures and onto the chest wall, that when you dissect, you may cause some bleeding. So are there any evidence out there or any consensus statement out there on the management of bleeding during VET surgery? Our president of SEEDS is part of this author group. There's so many authors in there, but yeah, it was published last year in the Annals of Translational Medicine in 2019. So let's go through some of the background for this consensus statement. The vascular injury happens in about 2.6 to 8.3% of VETS resection in the literature. Even in major thoracic centers that does a lot of VETS, their vascular injury rate has been reported anywhere around 3%. So it is not an infrequent process that you encounter a vascular injury. And a US database of over 600 hospitals, about 8,563 VETS lung resection, 9.2% require blood transfusion due to intraoperative bleeding. So it is fairly common in some of the hospitals in the States. And as we know, that major bleeding results in prolonged hospital stays and also increase in hospitalization complications and cost as well. So the main sites of bleeding, as identified in the paper, obviously the pulmonary artery, the pulmonary vein, also the bronchial artery, and also the lymph node beds, chest wall, the incision sites, and the bronchial and vascular stunt that you stapled off. And infrequently or rarely, the SVC, IVC, or the esophagus, or the aorta, or the systemic arteries, if you are doing some CCAM work or some other work, which we'll show you later on. For bleeding control, they recommend compression with gauze or suction catheter or adjacent lung or instruments. And then you have time to assess the need for proximal and distal vascular control, and you assess the need for conversion. In this stage, you must remember that conversion is not a failure. You are there to make sure that the patient has a smooth post-operative course. You don't try to be a hero if you feel that this is beyond VETS control, that you can achieve a control through VETS safely. So it is always a consideration to convert a patient to an open thoracotomy procedure so that you may have better access and also better proximal and distal control. You suture if possible, and you carry out your control if necessary, if ligation with the clips or the Hemologs. When the application of hemostatic materials are usually reserved for laceration less than 5 millimeter. But it shouldn't be a destination therapy itself. By that I mean that you shouldn't just rely on hemostatic material as the primary source of hemostatic control. You must always ensure that the laceration is either sutured or the proximal control is achieved with whatever mechanisms, stapling, clips, or Hemologs, so that you can have a good night rest. So the solutions to bleeding, obviously prevention is better than cure. Preoperative cessation of anticoagulation is feasible, but sometimes it's not feasible. If the patient has recurrent strokes or has severe ischemic heart disease, you may prefer to continue on the antiplatelet therapy. But it is very important that you have a pre-optimization of anemia and malnutrition so that they have enough coagulation factors in them. And for anemia, I usually have a preoperative transfusion for patients that has HP less than 10. Because if you spread out the insult, I believe that if you spread out the insult to the patient, they will do better. And transfusion is an insult to the patient's body. Some of our patients present to us post neoadjuvant chemotherapy, and they are a little bit anemic at the time of presentation to us, but you don't want to wait too long just in case the cancer grows again or spreads, and you may choose to top up the patient before the operation if the hemoglobin is a little bit on the lower side. For my threshold is less than 10, I like to top it out to before 10 before the operation. Now, obviously, meticulous pre-op planning, you look at a CT scan, you plan this out, you make sure that, you look at the vascular structures, you look at the pulmonary artery anatomy to make sure that there is no aberrant anatomy. Some of you may have access to CT recon. I think that that's a very useful way to plan your preoperative surgery. So the solutions to bleeding, majority is using energy. You have your dithermy, monopolar or bipolar. I like to use the ligature very much. Some people prefer to use the harmonic for as the means of dissection and also vascular control. Obviously, suture is a primary mechanism in large lacerations, Obviously, there are other mechanisms or other types of mechanism that you can achieve vascular control. You may use the titanium clips or the Hemologs or the vascular staplers. And this is the talk that I'll be giving later on, the use of hemostatic matrix as one of the solutions to bleeding. There are other adjuncts that you can use, such as Hemopatch or Neoview or your Tacosil or some of your hemostatic powder, such as Perclot or some of your sealants effect. So I'm mainly going to concentrate on FlowSeal as a hemostatic matrix today. So what is FlowSeal? There are two components to it. The first component is a cross-linked gelatin granules, and the second component is a human-derived thrombin. So what is gelatin? Gelatin does heat denatured collagen, and when you denature the collagen itself, the protein strands are in an irregular manner, and they can take up large quantities of water molecule. They allow swelling up to 10 to 20% as a tamponading effect when it's exposed to blood or moisture. So thrombin, as we all know, converts fibrinogen to fibrin, and the thrombin in the FlowSeal is human-derived, and in the FlowSeal box itself, there's another bottle that has a calcium chloride solution to that. You take the calcium chloride solution out, you inject it into the dried thrombin powder and to form a solution to that, and you mix it up together with the first component, that is the gelatin granules. That is the gelatin granules that's been described before. Okay, so FlowSeal works on two levels. One is a passive hemostat, so there's contact activation, so you have platelet activation, and the other one is the active hemostat, so you convert the fibrinogen to fibrin to form a stable clot. So as I told you before, FlowSeal, once it's exposed to blood or exposed to fluid, absorbs the moisture, swelling out about 10 to 20% within 10 minutes. And the active mode of action is that it converts fibrinogen to fibrin and allows the fibrin clot to form, and it prevents degradation as well if there's a dense concentration of platelets in the fibrin clot itself. So this is a validated intraoperative bleeding scale. Some of you may have seen it before. It is scale from 0 to 4. 0 means no bleed. 1 means bleeding from 1 to 5 mils per minute, which is really non-existent. Grade 2 is 5 to 10 mils per minute. Grade 3 is 10 to 15 mils per minute. And there's spurting, and they describe it as overwhelming flow. But actually, 50 mils per minute, or let's say 60 mils per minute, you're only having 1 mil per second. So that is a very manageable blood loss that you can probably control with VETs. So the grade 4 is that it is life-threatening bleeding that is more than 50 mils per minute. That is continuous spurting when you press on it and it's still bleeding away. Then there will be a situation that you have to be alert. So how do they position this hemostatic matrix? They position it as up to grade 3. You can control bleeding from up to 50 mils per minute. But personally, if there's anything spurting, I'll not use it as a destination therapy. Anything that is continuous flow, even in a low pressure system, you could consider using it, or you could consider using a hemo patch to seal up the laceration. But anything that's spurting, that's more than 50 mL per minute, you can use it as one of the adjuncts to slow down the bleeding itself. So what's the evidence behind that? So majority of evidence of FlowSeal usage comes from cardiac surgery. So this is a paper in 2009 from the Annals of Thoracic Surgery from Italy. They have about 415 patients enrolled into the study, about 209 patients in the FlowSeal arm, 206 patients in the control arm, and they are fairly well matched to the type of surgery, the risk for the surgery itself, and the length of cardiopulmonary bypass itself. So what is the result? The FlowSeal group has a shorter time to hemostasis. They have a shorter time from decannulation to sternal closure, less post-operative blood loss, and less blood product transfusion. And the reason why I'm in concurring with this is because I have a fairly liberal use of FlowSeal in my own cardiac practice. Our transfusion rate is less than 15%. And majority of the patient within this 15%, if they require transfusion, only has 1 unit of red cell concentrate transfused at the time or post-operatively. And their mean drop in hemoglobin level after cardiac surgery is less than 3 grams. Obviously, we use cell salvage as well. So with a policy of liberal usage of FlowSeal and also cell salvage, majority of patients undergoing cardiac surgery don't really require blood transfusion in our center. And with that confidence in using it for cardiac surgery, I have extended it to patients in thoracic surgery as well. I'll share with you some of our center's result later on. So the evidence of usage of FlowSeal in thoracic surgery, there's also a paper out there. It's a randomized study. It's also conducted in Italy. The recruitment period is between March 2010 and December 2011. And bleeding is defined as pulsatile continuous bleeding despite pressure for 2 minutes or the usage of electrocautery. And the patients are randomized to standard care or versus standard care plus FlowSeal. So standard care includes ligature, sutures, electrocautery, and direct compression itself. So the group characteristics, there are 60 patients in each arm. The main site of bleeding obviously is in the pulmonary arterial site, followed by the lymph node dissection site itself. And majority of the pulmonary artery bleeding is probably just from the staple line, and rather from actual vascular injury. So the results, the intraoperative bleeding control was quicker in the FlowSeal group versus the standard of care or standard care group. At 3 minutes, 78% of the FlowSeal group achieved hemostasis, and 6 minutes, 92%, at 10 minutes, 98%. So it is all significant as compared to the standard care group. The post-operative hemoglobin dropped was significantly lower in the FlowSeal group as well. The preoperative hemoglobin, mean hemoglobin was about 13.4, and they only noticed a 0.7 gram drop per deciliter post-operatively in the FlowSeal group. Certainly is borne out by our center's audit for our last 150 cases. Our average hemoglobin dropped after major VATS lung resection is about 1 gram. Preoperative hematocrit was about 40.6 in the FlowSeal group, and a post-operative hematocrit drop in the FlowSeal group is about minus 2.6. So these are all pretty significant between the two groups itself. So this is a patient that has a redo surgery, and as described to you before, is a paper thin inferior vein. You could see that with each pulsing of the heart, you could see the wall. And to stitch this, we did underwater testing first for the air leak, and also you can identify the site of bleeding fairly easily underwater. And to stitch this is possible, but you have to be careful as well, because when you apply a suture, sometimes your needle hole may create more of a problem, or when you're tying the knot down itself, you apply too much pressure, it may cause an even worse tear in the paper thin vessel. So we just decided that this is probably, grade 2 bleeding, then it can be controlled adequately with a hemostatic matrix. And after 3 minutes, it looks pretty well controlled. Let me put a little bit of Surgicel just for added safety. So sometimes when you're dissecting on the lymph node beds, you cause some rawness around the area, the station 7 lymph nodes. I think this patient had preoperative chemotherapy, and we just did a lower lobectomy, and we're dissecting away the station 7 lymph nodes. I use my energy device of preference is ligature, and we'll show you where the right main bronchus and the left main bronchus are in a very short while when we clear out this lymph node packet from the subcarina area. So this is just some energy device being used. You can see the esophagus towards the back that's pushed away by the sucker, and we're just gently teasing the lymph node packets away from the left main bronchus itself. So we're just dissecting this lymph node packet out itself. So sometimes with angiocrotic nodes or patients with very bulky lymph nodes as post-therapy, they might have more adhesions along the hilar structures or subcarina structures, and you may have more raw area. So inspect the area after you dissect cleanly. Some oozing that you'll notice. You can pack it with a gauze first and see. But in this case, we elected to use some flow seal because within a minute of not compressing, the oozing is back. So we put a hemostatic matrix in and pack it for 3 minutes, and they achieve very good hemostasis itself. The manufacturer's recommendation time is packed for 2 minutes, but just a little bit kiasu, so I will pack it for about 3 minutes, just to be on the safe side. And you do your underwater testing again. I love underwater testing, both for air leak and for bleeding identification, because anything you could see very clearly under clear water So if there's blood, when you wash out the first time, there's blood, just suck it out first. And if there's blood the second time, just suck it out first. Just suck it out until the water is clear, so that you can put your camera underneath it into the water to identify sites of bleeding or sites of air leak itself. It's pretty much the same, station 2 and 4 bleeding. I wouldn't go into that. So the conclusion is that bleeding in thoracic surgery is not infrequently encountered. Meticulous planning and careful operative dissection is key. A wide range of hemostatic products are available as adjunctive therapy, and a hemostatic matrix should be readily available. We will cover a wide range of bleeding scenarios itself. So, like I explained to you before, a lot of our patients do have concurrent diseases that is on oral anticoagulants. So if you're a hemostatic matrix, even though it might be a little bit expensive to apply them during the time of surgery, actually you are saving cost. There are papers out there that shows cost reduction in terms of hospitalization, length of stay, and complications, and also reduction in blood loss itself. So just prompt to you, audience out there, SEED's online video submission is open. This is the URL. You go there and you can look at some of the submission guidelines, free submissions, and there are prices for best video submissions. So if anything interesting, any interesting video to submit, please visit the SEED's website for the video submission guidelines itself. So do visit our website. With that, I thank you.
Okay, thank you, Mr. Sun, and thank you, Dr. Antonio, for two wonderful presentations. And surprisingly, today we have no Q&As until now. So let me start by just asking Dr. Antonio a very fairly practical question. You have got a very good series of surgery for aspergillosis, and I think these are challenging surgeries even for the senior thoracic surgeons. Does it come in your practice that do you do pre-op angiogram prior to operating on all these patients and probably embolizing the large vessels before taking them into theaters?
Thank you for the question, Dr. Siva. The high-resolution chest CT scan, if we sit down with a radiologist prior to the surgery, we can follow actually the blood vessels, pulmonary arteries most especially. So we'll know where to look for them. And if they're big or if they're small, sometimes you dissect and say it's too big a vessel to be a branch, especially in bronchiectatic patients or in chronic inflammation. But if we are fairly confident because we sat down with our radiologist prior, then it really helps a lot. It can request for a reconstruction of the blood vessels in the high resolution contrast chest CT. Now, as far as bronchial artery embolization is concerned, we have the occasion to do that in patients who are poor risk for resections and who have bleeding or hemoptysis. It's quite expensive, but we have interventional radiologists who are very proficient in doing embolization of bronchial arteries, and they can control the hemoptysis.
Okay, thank you, Dr. Antonio. And Mr. Sun, what is your opinion regarding the practice of applying hemostatic agents on vascular stumps after using staplers during your VATS resection or even open resection?
I think if it is oozing and it's sometimes during VATS procedure, you may have a little bit more tension onto the vessel when you staple. So sometimes there may be some slight oozing from the vessel. I think with 3 minutes of compression, either with a peanut, if it doesn't stop, I think you're justified to use some hemostats on that, just to decrease the amount of blood loss after surgery and also prevent you from having to re-exploit patients after you have closed out from continuous leakage. And also you would decrease the amount of complications in terms of blood transfusion requirements. Some of them you may predispose them to chest infection or pneumonia or renal failure if you transfused, especially in patients with borderline renal function.
Okay. Still no Q&As from the floor, then I've got to ask another one to Dr. Antonio. Now, you've also put up your slides on, you've done a lot of VATS decortication and also a lot of open decortication cases. Now, looking at the CT scan on the preoperative state, what are your criteria you would look at to decide whether this case would be suitable for VATS or this would be open? It's mainly for the trainees and the newer consultants who are embarking into decortication surgery.
Yeah, basically, that's a very nice question. So you will not run into problems. Basically, if it's a bacterial pneumonia, the decortication should be fairly easier, than compared to decortication done for TB, tuberculosis, because the chronicity of the thickened pleural, or the pleuritis, the chronicity makes it very difficult to peel off if it is secondary to TB. And most of the time, we have to do open thoracotomies for decortication for TB. But for bacterial pneumonias, it's just like removing the peel from an orange. It is quite easy.
So Tony, let me ask you, from the left upper lobe, what are your tips and tricks to avoid recurrent laryngeal nerve injury and also to avoid subclavian vessel injury?
Well, if you're doing extrapleural dissection, you should stop when you're nearing the apex, because that is where the danger is when you're going to hit the subclavian vessels. Now, as far as the recurrent laryngeal is concerned, since you're operating on an inflammatory problem, you do not have to really get a good margin. If you're not sure about the area around the aorta, you can just leave some of the lung tissue behind using energy device. But surprisingly, the aorta is relatively free from adhesions, even in tuberculosis. I do not know why. You can usually find the space, and with it, you can also identify the recurrent laryngeal. But yes, it is possible to injure it in very dense adhesions, especially in the hilum in tuberculosis. So extrapleural, when you hit the apex, be careful about the subclavian vessels. We go intrapleural when we reach the apical part.
Okay, I've got two questions now. Thanks for the presentation. My question to Dr. Tony: decortication of empyema cases in most instances are associated with wound infection and breakdown. Is there any method or way to reduce the incidence of wound infection?
I have no evidence for this. But the practice is we do lavage of the pleural space. But before we close the ports or we close the thoracotomy, in the subcutaneous layer, the nurses in the operating room know this. I asked them to give me a mixture of peroxide, hydrogen peroxide and betadine. I really give it a good wipe down before putting in a subcutaneous layer of suture. And I learned this from my general surgery when we're doing appendectomies, especially the ruptured ones, that we realized we had less SSIs because of that.
So what's your concentration of hydrogen peroxide that you use?
The usual, it's I think it's 10% if I'm not mistaken. The usual preparation of hydrogen peroxide and 50% with betadine, povidone iodine. And it also helps in hemostasis. Imagine when in orthopedic surgery, you put peroxide and the small oozers, they stop.
Yeah, especially a chest wall.
Yeah, it also helps in hemostasis, but I use it for infection control. And it's been a practice of mine ever since I was in training.
Another question also to Dr. Antonio. I'm not very clear what the question is, but they ask here, should we need to administer antifungal post-operative? I think they're probably referring to
Aspergiloma.
Aspergiloma.
And what is your situation for the time?
With Aspergiloma, really, the infection is just inside the TB cavity. It is not just like aspergillosis, which is a pneumonia aspergillosis, wherein you have to really give antifungals. But if you resect the lobe with the fungus ball or mycetoma inside, there is no need for antifungals. And I do not recall giving antifungals for after resection for mycetomas or aspergillomas. I don't know about Sun. Sun, do you give antifungals?
Yeah, in a previous center where I worked in Manchester, we have the UK Aspergilloma Center. So the chap there, Professor Dunning, is the UK authority on Aspergilloma and aspergillosis. Routinely, he will continue the anti-fungal treatment for about 6 to 12 months after our surgery, routinely.
Amphotericin B, he uses amphotericin B.
Routinely.
Okay. All right. I mean, this is another question of mine to Mr. Sun. Now, bleeding is always an issue that we can anticipate, we can't anticipate. In cases where you can anticipate, especially during vet surgery and all, any tips and tricks on proximal and distal control for the right side and for the left side, especially hilum dissection, mainly for those embarking in vet surgery, to ensure that they can get a control even they run in trouble?
Yeah, so if the vascular injury has already happened, obviously pressure is the main thing that you need to do, and you will want to have a look to see how you can achieve proximal and distal vascular control. Sometimes you may have to go intrapericardially for the vascular control, especially on the right side. If you are injured fairly high up in the right main pulmonary artery, you may have to create a pericardial incision to achieve the pericardial control. What I really like is either endoscopic bulldog that you can apply to achieve the vascular control, or that you do a double loop sling and you can tighten on this double loop sling. Is more atraumatic to the patient, and you can guide the pressure to exactly the amount that you require. When you do the double loop sling and you are able to guide the pressure, you can apply liger clips onto the sling itself so that it stays at the exact pressure or exact tightness that you want. So when you pull the double sling up and it narrows down, then you apply large liger clips onto the sling itself so to maintain the vascular pressure, vascular compression, and then you are free. It is out of the way. There's no big instruments in there, no big clamps in there to get in the way of your suturing. Obviously, you might want to consider going around the veins that is left behind to prevent retrograde bleeding as required. So those are some of the tips. Siva, we cannot hear you. You are on mute.
Sorry. Okay, it's 9 o'clock. There are no more questions from the floor, and I think it's been a very good session by Dr. Antonio and Mr. Sun. With that, for today's series, we thank you all for attending, and we'll see you all again next week. Thank you very much. Thank you, Mr. Sun. Thank you, Dr. Antonio. Take care.
Thank you, Tony.
Thank you, Sun. Thank you, Dr. Siva.
All right. Good night.
Bye.
Bye. Good night.